types of governance education is offered to ensure board members thoroughly understand the importance of quality? Do you recruit board members with quality expertise in mind? Have you assessed your committee's effectiveness in the past 2 years? If yes, what was your main improvement priority? Does your organization actively look to learn from and implement changes based on harm events?
In terms of top tips to a board learning from harm, the first thing the board needs to do is get educated. So kind of a structured continuing governance education program. The next thing that really effective boards tend to do is they try to recruit someone on the board who has quality expertise. Not necessarily in healthcare, but expertise in systems improvement, in Lean or Six Sigma or manufacturing or engineering or nuclear power safety. There are literally dozens of disciplines that focus on safety, including in healthcare, which are generalizable to healthcare. And this is also important to point out, just because someone is a clinician, if you have a doctor on your board or a nurse on your board, that does not mean they're a quality expert. So one of the first tips is put someone on your board who's a quality expert, who can go more than 6 or 7 questions deep, who understands statistical data, who understands systems theory. Secondly is you've got to educate the entire board to a standard of quality literacy, so that even though I'm not a quality expert, I can speak the language. I understand why the board's responsible for quality. I understand what happens if a board doesn't effectively exercise that oversight responsibility. I understand how to exercise that oversight responsibility.
I think there are a number of important things that board members who would like to serve on a quality committee ought to take advantage of or make sure are offered to them in terms of making their service more effective. I think getting an orientation to your role and responsibility as a quality committee member is paramount in this environment today. It's a complex area of oversight. There are a lot of measures, there are a lot of goals that are being set, and there are a lot of performance improvement tools and reporting and other measures that board members may not be familiar with before they come onto the committee. So a good, strong orientation to the role of the committee, its charter, its roles and responsibilities, how to read the performance reports, what questions you should be asking if you're looking at performance variation. Why does performance vary from a target or a threshold? What are we doing to address that? And then making sure that the board continues to monitor those interventions so that we can in fact verify that quality has been improved.
We don't regard quality as something that's separate from the everyday operations of our organization. It's something that has to be part of the fiber. For our board members to understand the fiber of our organization, we do monthly 2-hour education sessions for all of our board members to make sure they understand how quality is important, how finance is important, how advocacy is important, what their role is as a board member, and how that all gets woven together as part of their role as a leader of the organization. We look for our boards to really lead. I think there's a temptation for boards to think that they're representative of the community or representative of the patients, and that's true. But they really have a higher calling in leadership. And unless they fully understand not just the mission of the organization, but how the organization actually accomplishes that mission, they can't have the engagement that they need to help us move forward.
To begin to go down the process of establishing the big goals. So, and that's very, very important for the board to have that debate and that discussion. The doctors, the medical staff can have input, the executives can have input, but the board really needs to debate this, because you get some very, very powerful kind of transformative moments when the board is debating this. When you're debating, for example, how many preventable mortalities are acceptable. You know, it's not long before some board member says, wait a minute, you know, why shouldn't the goal be 0? They have to set big picture goals. They have to be working toward accomplishing something in particular. So the boards that are most effective at improving quality are trying to accomplish some specific target. For example, reduce their mortality rate by 20% in 18 months, and then a very specific set of measures that will then tell them whether or not they've reached that target.
All boards and their committees should at least biannually undergo a self-assessment of their performance and effectiveness. Out of that assessment should be developed a work plan, either at the board level or the committee level, to address gaps in their performance and to lead to improvement. After all, the board is holding the organization to continuously improve and to continuously monitor its performance, so the board should lead by example in routinely monitoring its performance and engaging in improvement activities as well.
All quality is high. quality is real high. In fact, our strategic plan, we have a strategic planning cabinet that works, and quality is the driver of the bus. When we look at each one of the stated objectives within our strategic plan, quality has to factor in and see what's realistic, where we're going, how do we accomplish it, and what are the impediments. So when we identify what those impediments are from the standpoint of our strategic plan, then it encompasses us to recruit more people to the table to achieve that objective. As you begin the journey and you just start off on a board, you get to learn all the medical terms and you kind of overwhelmed. And quality could very easily be lost in that shuffle. But as you continue, and in my 9th year on the board, it's something that I've come to appreciate, that it is so important that if we don't emphasize it, and if we don't keep it at the forefront, and if we don't keep management's feet to the fire when it comes to those, and if we don't have the checks and balances in place, it'll definitely impact negatively our ability to provide great customer service, great patient satisfaction. So I think quality is something that as board members and trustees, we have to continue to emphasize. We have to continue to learn the broad spectrum of exactly what's out there, and provide those resources to management and to our staff to get the job done.
So the good news is there are examples. You think about any organization, that there might be, and if I'm a board member of that organization, there is someone out there who has done what I am trying to do. And as long as I'm willing to learn from them, I can make the quality better for my neighbors, for my relatives, for my business associates, for the people who live in my community. So the work of the board is never going to be done, just like quality work or patient safety work is never going to be done, because the more we do, the more we learn, the more we try to set up systems, the more we understand how fragile our underlying systems are, and we're really fundamentally trying to change the entire culture of not just the hospital or health system, but the American healthcare system. So there's plenty of work for many years to come.
I think there's a tendency at the board level to want to talk about good news and to want to bring good news to the board. I think it's the board's role to dig deeper and to say, we're glad to celebrate and hear about the accomplishments, but we also want to know where you're having problems. What are the greatest obstacles and challenges that you're facing? What have you learned about from a sentinel event or an incidence of harm that could have been avoided? A near miss, for example. We talk about those at our quality committee, and we talk about those at our full board, because we always want to be looking at opportunities that we can learn from and hopefully not inflict unnecessary harm on our patients.
The board needs to put a face on the data so that the board, when it sees the data, can say, wow, we had 4 patients that got a completely preventable central line bloodstream infection last month in this hospital. The next step, once you do that, is to ground the data in patient stories. So really effective boards that oversee quality will hear a patient story at every board meeting. And some boards will set a rule. They'll say, we only want to hear stories that show something that happened that was untoward. We only want to hear bad stories that portray a mortality through a relative's perspective or portray a bad experience through the patient's perspective until there are no more negative events, until there are no more preventable mortalities. And this is very useful because it then grounds the data. We only had 4 central line bloodstream infections all last year. That's not so bad, especially because the year before we had 20. And unless you really are very motivated, you're likely to stop there. But if you hear the story of a patient who had a central line bloodstream infection, or the story of a patient who lost their mother or their child because they got a central line bloodstream infection, it steels the board's resolve to say, even though we're much better than we were, we're not good enough. We need to get to 0. We need to get to 0. And increasingly, this combination of the data and the patient story will really encourage and push boards to embrace a standard at one of 2 levels, 100% or 0%. Something should always happen or it should never happen.
Organizations must have specific, measurable targets for improving quality and eliminating patient harm. These should be big picture goals and should be used to hold leadership and staff accountable for performance. Boards should assess and continuously improve their quality and safety literacy through education and working with individuals who possess specific quality expertise. Boards should employ strategies like hearing directly from patients to help humanize the data.